whole neuropsychological or rehabilitation process, but also to use different psychological interventions like cognitive behavior therapy, behavior modification programs, psychodynamic therapies, and also how to work not only alone with the client, but also to involve the families and the carers and others in the program. So before even we plan a cognitive rehab program, it is very, very essential to have a thorough neuropsychological testing. So neuropsychological testing helps to throw light on the patient's cognitive strengths and weakness. But again, there are limitations. Very often we have seen that we get a lot of cognitive deficits on a formal testing, but in real life we see that the patient is able to function, also the vice versa. The patient is able to do the function in real life, but when we see that these activities are really not in keeping with the pre-morbid functioning. They are doing some functions, but when we compare it with the cognitive profile, we see that there is an impairment which explains why the person is not able to function at a higher level. So before we plan a cognitive program, neuropsychological test findings are definitely essential, but it is also very important to see how these functions are affecting the patient's day-to-day life. So we need to have a detailed functional and behavioral assessment in order to engage a person in cognitive rehab. So what do we need to see? Which problems are causing the greatest difficulty to the person and to the family? Are the problems clearly defined? For example, majority of the patients, even you have experienced, when they come to you, they say, oh, I have a memory problem. But what do you mean by a memory problem? That has to be defined. Is the memory problem for an event? Is the memory problem for a word? Is the memory problem a problem having difficulty in recognizing the face of a person, for example, a family member? So to everybody, to our patients, a memory problem is just everything. So it is our duty as clinicians to pinpoint, to find out what exactly they mean by a memory problem. So that is the thing what I have outlined, that the problems need to be clearly defined. What are the coping strategies the patient is using since the time he is having the problem? Whether the problems are exacerbated by anxiety and depression. What was the pre-morbid functioning? The person's social, personal and family context. Return to work issues is a very, very important question which I face in the daily practice after head injury. Like many of the patients are referred to us by neurosurgeons to tell whether the person can go back to work at all. So this is a very important issue we need to consider during rehab. And whether the patient is likely to undergo recovery. Even before we plan a program, we have to be very honest and tell the family members, even though they are referred to us, whether the recovery is possible. It depends on the time after which the patient is coming to us. For example, if the patient is coming after 1 year from head injury, we really can't do much about it. And also the loss of consciousness, like how long the patient was unconscious following head injury, whether it was a transient loss or whether it was weeks or whether it was months. That also determines the recovery period, the recovery the patient is likely to undergo. Now, so at Oliver's Angle, there is a big team which is working, and the team consists of neurologists, psychiatrists, psychologists, occupational therapists and speech and language therapists. But we are really not fortunate to have the entire team working together, because even before they start the program, the entire team sits with the patient and the family to discuss whatever I have discussed in the previous slide, the pros and cons, the social context and everything, to formulate the program. So during assessment process, the team works with the client to develop a formulation which is a way of representing the difficulties experienced by the client and how these difficulties affect each other. There should be a good understanding between all the therapists in the team and also the client and the family members. Now there are different cognitive rehabilitation models, but the biopsychosocial approach has been shown to be very useful. It is basically influenced by the World Health Organization International Classification of Functional Disability and Health in order to understand and represent the person after his or her brain injury. Now what is a biopsychosocial model? I'll try to put it very simply. So just forget the two arms of the slide. Just focus on the middle part. So according to the WHO model, it is very important to integrate cognitive, emotional and behavioral process in the rehab. The person with the injury has to be engaged. It is very, very necessary to incorporate the practice of strategies and skills in the person's own meaningful social context. So what happens, they have termed it as body structures. It can be a physical problem also, but since we are dealing with brain injury, I have given the picture of a brain. So there is a damage to the brain, and that leads to body functions impairment. In case of brain injury, what are the functions which can be affected? It is the cognitive, emotional and physical. So during neuropsychological assessment, we focus on the cognitive and the emotional part. We leave it to the physician and also to the occupational therapist, and how these changes in the functions affect the person in everyday life. So what Barbara and Jonathan did was to incorporate the model in their system, and they also brought about the role of family and social support and the premorbid factors, and also the insight and motivation, which is very, very important, because every time I'm repeating, the client needs to be engaged. So a client the patient who does not have insight into the cognitive deficit, how can I help the person to engage in some activity? So now I will try to discuss that model in relationship to one of my patients. So patient DB, who was 26-year-old male, visited me, I think, for the first time the last week of June. He suffered from a road traffic accident in 2012, was unconscious for about a few weeks, I think 3 weeks if I remember correctly. And then he suffered from post-traumatic amnesia, which lasted for 2 months, and there was one episode of seizure in July 2013. The MRI of the brain showed subdural hematoma. So according to the patient and his mother, he is forgetful. You can see I have not defined the problems clearly. He has difficulty in finding the word, for example, names of people, actors and people who are close to him. He has attention deficit and restless. He does not maintain hygiene properly. He tends to have a bath in a haste, and there are also behavioral changes. So this boy was a very enthusiastic. He was outgoing. You can go to the next slide. Before I go to that, so on neuropsychological test we found that he was average in intellectual functioning. His score was 97. His attention was impaired. He had retrieval deficit for both verbal and visual material, and there was impairment in executive functioning, mainly planning and I think verbal fluency, and he also had naming difficulty. So now I have tried to explain basically the patient's name is Dhiman. I've tried to explain Dhiman's problems with the biopsychosocial model. So Dhiman had a head injury. Now what are the areas which have been affected in Dhiman? Dhiman has a memory problem. And when we asked him what do you mean by a memory problem, he said that he is unable to retain any information more than 15 minutes. For example, what he did in the morning, what he did in the evening. He forgets name of Bollywood actors because he was very interested in movies, and he also forgets names of cricketers, soccer player also. And he is not able to see any movie or talk to anybody for more than 5 or 7 minutes. His mother says he just leaves the place while he's talking to somebody. And he has marked word finding difficulties. He has a low mood, he's very depressed. Dhiman, as I told you, was a very outgoing person. He had a lot of friends, he was always on social network, and at the same time he had a very good business even at that age. So he was basically keeping himself away from his friends. He had a very good insight about his cognitive deficit. So what Dhiman told us, see, I read the newspaper but I'm unable to remember. So what am I going to discuss with my friends? They are very updated. Neither can I discuss any recent events with my friends, neither can I discuss any entertainment with my friends. So I prefer to be away from them. So he had a very, very negative self-perception. So his self was threatened. And that led to his low mood. A cheerful person just going into very low mood, and he always doubted he had a lot of self-doubts. He also had corneal ulcer and loss of vision in the left eye. But according to Dhiman's mother, what the doctor had told him was, it was really not that bad. And Dhiman was also very concerned because he was a very handsome guy. His mother showed his picture also. There was a lot of change in facial expression, and that was also the reason Dhiman wanted to keep himself away from friends. So what is happening? There is a brain structure which is involved, which is affecting his functions cognitively, affectively, and the physical part also. And these are all affecting Dhiman's life in different ways. There are behavioral problems, there are occupational problems. So you can see that these are all interrelated. We just can't target only the cognitive part for rehabilitation. The entire perspective of the individual has to be considered. Next slide. So now what is the best way